Hello everyone, and welcome to the Montana Integrated Behavioral Health webinar, Alternatives to Pain Management. My name is Libby Ethier, and I'm the Project Coordinator for Practice Improvement at the National Council for Behavioral Health, and I'll be filling in for Leah Sims as your moderator today. Before we begin, I'd like to cover a few housekeeping notes. Today's webinar is being recorded, and all participants are currently in listen-only mode. You can find the call-in number for the webinar on the right-hand side of your screen. Please make sure to enter your audio PIN, also provided with your call-in information, in the GoToWebinar window. You may enter your audio PIN at any time during today's session by pressing pound, followed by the audio PIN number, then pressing pound again. Entering your audio PIN is the only way you will be able to unmute your line. If you have a question or comment throughout the presentation, please use the raising hand icon and we will unmute you. Alternatively, questions can be submitted throughout the webinar by typing your question into the dialog box on the right of your screen and sending it to the organizer. We'll answer as many of your questions as time allows at the end of the webinar. Following the webinar, we invite you to please complete a short survey. An audio version of the entire webinar and a PDF of the presentation will be archived on the Montana Healthcare Foundation webinars page. If at any point during the webinar you experience technical difficulties, please call Citrix Tech Support at 888-585-9008. Our presenter today is Nick Szubiak. Nick brings more than 15 years of experience in direct service, administration, and clinical supervision. As the Director of Clinical Excellence in Addictions at the National Council for Behavioral Health and as an integrated health consultant, he provides technical assistance, consultation, and training towards bidirectional integration of behavioral health and primary care, expert, and substance use treatment such as medication-assisted treatment, MAT, and helping organizations utilize data to improve clinical outcomes. Nick's training experience fosters both primary care, substance use, and behavioral health care providers' successful adaptation to clinical and organizational culture change. So without further ado, I will hand things over to Nick.
Libby, thanks so much, and thanks everyone for joining. I was very excited when Joan King asked me to do this webinar and work with you folks in Montana. I had the fortunate experience to work out in Dillon with Joan, just a little bit over a year ago, and it's so great to be able to be back with you virtually and to talk a little bit today about some alternatives to treating chronic pain. You know, the work that I did before I came to the National Council was in a community health center, and a lot of the work that we did was with working with patients with chronic pain management, and that was in an integrated care setting. And really, it was an area that I had to learn and develop to bring in a lot of the experience I have as a behavioral health provider to working with our docs who were doing a lot of the pharmacological interventions around chronic pain management and how to bring those two together. So we're going to dive into that a little bit today and talk about some non-pharmacological evidence-based practices on treating chronic pain. Specifically, we're going to review and talk about cognitive behavioral treatment. And so for today, we'll call that CBT or CBT-CP, which is cognitive behavioral therapy for chronic pain. The other evidence-based practice that we're going to focus on is acceptance and commitment therapy, ACT, and also mindfulness. So a lot of this webinar, I got information from a very valuable resource that I used when training our staff at the community health center I worked at. And the link is there below. It's from the actually the Veterans Administration. And I really encourage you, if you want to take a deeper dive into some of the things that we're going to talk about today, to go ahead and take a look at that document online. So our objectives today are understanding what is chronic pain and acute pain and the differences between those two to gain an understanding and recognition of treatment options for chronic pain. We're going to talk about the different medications, some of the medical treatments, and some of the non-invasive treatment options that we have. And again, that's also to get us familiar with the language. We're also going to be able to identify and describe 3 non-invasive treatment options for chronic pain. And then also really understanding the influential factors in pain, this from the psychological perspective, behavioral, and social. So biopsychosocial approach. And then also we're going to review and take a look at measurement-based care for chronic pain. So taking a quick look at screening tools and how to use those tools over a continuum of care. So before we dive into treating chronic pain, I think one of the things that's really important for us to talk about, and probably most of you are aware in your community, the impact of the opioid epidemic. But one of the reasons that non-pharmacological interventions and are getting some attention and more attention, and this is I think one of the lemonade that comes out of the lemon of the opioid epidemic is this sort of attention, is that drug overdose is the leading cause of accidental death in the U.S. We know that that is in a large part driven by prescription opioids. And we know that with 20,000, and there's new 2016 slides data that just came out, and these numbers have all gone up. But there's 20,100 overdose deaths related to prescription pain relievers, and almost 13,000 overdose deaths related to heroin. And we know that many of those deaths related to heroin are started from folks who were using prescription pain medications. And so the overdose death rate, sales and substance use disorder treatment admissions, they have all rose in the same way. And so in 2012, 259 million prescriptions were written for opioids. So that's enough prescriptions to give every adult American their own 30-day supply of Vicodin. And again, you know, the impact of the heroin use, 4 in 5 new heroin users started out misusing prescription painkillers. And this is a chart looking at overdose death and the impact that heroin is having on our communities. We've all heard about fentanyl and the dangers that brings. And so it's just important that we're aware that we really need, if we're going to address the epidemic in our communities, really need to address hitting it in all different aspects along integrated care. And treating chronic pain with non-pharmacological interventions is an exciting one because it's also really effective. This slide I want to point out around overdose deaths also is interesting too, because it does have listed on here methadone. And, you know, it's important to point out that methadone is used to treat opioid use disorder in outpatient treatment programs like methadone treatment programs. The death rate around methadone use is not strongly connected to the use of methadone as a MAT medication. What we're talking about in this graph primarily is the use of methadone as a pain medication, which typically comes in pill form and is not monitored in the same way methadone in the liquid form is monitored in a methadone maintenance treatment program. And so in those programs, it's much more highly regulated. And that's why I just want to point out that difference, because there can be a bias towards the use of methadone to treat opioid use disorder. And it is just that, it's a bias, it's not a fact. And so this is an older statistic, but I think really important for us to look at this increase in opioids from 1997 to 2007. And again, why this jump? Part of it had to do with a lot of different factors, but a big part was the movement of making pain one of the vital signs. And so I remember in the late 90s, I was actually working in a drug and alcohol rehab center, and the Joint Commission mandated that we start every week measuring and asking patients our pain levels in a 30-day rehab setting, which was very interesting and really speaks to the swing of how pain in this country went extremely undertreated to the opposite side, where we really began to overtreat it with medications. And so, according to the Institute of Medicine, pain affects millions of Americans, contributes greatly to national rates of morbidity, mortality, and disability, and is rising in prevalence. And despite the fact that we're prescribing all these medications, and you can see here that we in this country consume 80% of the world's opioids, yet we are only 4.6% of the world's population. So you can see a great disparity here. And despite, I'm having a little trouble with my slide. There we go. Thanks, Liddy. So, and despite this increase, this dramatic increase in prescribing pain medications, this is a really interesting way to look at how well we're doing in treating chronic pain. And this is a graph according to years lived with disability in the thousands. So it takes folks who have a disability and compiles those years of living with a disability into the thousands. And we can take a look from, in the blue, from 1990, and in the red, 2010, how actually the years of people living with a disability is getting worse. It's increasing rather than decreasing. And that is in complete contradiction to the amount of opioids that are being prescribed. And so let's take a look real quick at the effectiveness of these pain medications. And again, this is some interesting data for us to take a look at. So this is from the Cochrane review, and this is the percent of people getting 50% pain relief. And the first bar that you're going to see is from 2 5-milligram Percocet pills. And so that brings us up to about 35%. And then we're going to see what the percentage is of people getting 50% pain relief with ibuprofen. So take your guess. Do you think it's going to be higher than 2 Percocet pills or lower? Well, you know what? It's actually the same. Very similar, very close. And then ibuprofen, 400 milligrams. Taking a guess, higher or lower? A little bit better with ibuprofen. And then oxycodone, 15 milligrams. Actually quite lower, 20%. And then acetaminophen, so Tylenol, close to 30%. And then finally, we're going to take a look at the combination of using ibuprofen and Tylenol together in a combination equaling 200 milligrams of ibuprofen and acetaminophen of 500 milligrams. And incredible, it's significantly higher of the percentage of people getting at least 50% pain relief. And so I always like to throw this chart up because a lot of times we live under a mythology that opioids are the only way to treat pain. And sometimes that's a bias or a myth that we're operating under. So the adverse effects of opiates. Well, short term, we know that folks, some of the negative things that our patients are experiencing on opioids are sedation and also GI tolerance. We see constipation, nausea, and vomiting. And then the long term, we see tolerance. So what that means is our patients need more and more of the medication to get the same effects. And then dependence, where they've developed a dependence, and certainly concerns over development of that dependence changing into addiction. Those are two different things, but one certainly can turn into the other addiction. And then hyperalgesia, which really is kind of the story of diminished returns around opioids, that the longer you stay on opioids, the less impact they have, not only in terms of tolerance, but also the body's ability to tolerate pain. That we actually see folks having an increase in the amount of pain that they experience the longer that they stay on opioids. And so that certainly is a double-edged side of a sword that is not talked about enough and is an important part of how we need to educate our patients in terms of, you know, in combination with our docs, certainly, but talking about the long-term effects of staying on opiates as a long-term solution to dealing with chronic pain. And then the mood-pain connection that we're going to talk about today as well, that we know that folks who have depression that lowers their pain threshold. And then also with anxiety, that it increases muscle tension and increases pain and exacerbates areas of chronic pain for folks. And pain is real. Pain defined here as an unpleasant sensory and emotional experience. It's both. It is the integration of physical and emotional experience associated with actual or potential tissue damage. It's a very interesting definition. Actual tissue damage or potential tissue damage. And that potential piece we're going to get into a little bit speaks a lot to the emotional effects of chronic pain, or describes in terms of such damage. So again, the emphasis here is that our patients that come in and that we're treating for pain, this is a very real issue, and that is also can be challenging because we know pain is a subjective experience, and why we're going to talk about measurement-based care is such a critical part of the work that we do. So today, talking about two different types of pain, we're focusing on chronic pain, but it's important for us to make the distinction that acute pain is less than 3 months. It is a symptom. There's an identified cause. It's the body's response to an injury, and it diminishes with healing, and it's responding to treatment. That's the definition of acute pain. The difference, chronic pain, is that it's more than 3 months, and it's a condition, not a symptom, a condition. And it may develop after an incident, but it also may have an unknown cause. We may not know where this is coming from. And it persists beyond expected healing time and or despite treatment. And so pain, chronic pain, as we talk about it today, is a chronic health condition. It continues in the absence of ongoing tissue damage. The nervous system itself is misfiring pain signals. So this is an ongoing process, and it's best understood as a chronic disease to be managed versus an acute symptom to be cured. And so these are some types of pain that we're going to talk about today. And some of the next few slides I'm going to bring up are loaded with information. They're not meant for us to read today. I'm not going to read them to you. But this slide deck for you is a reference guide. So those of us working in chronic pain from the behavioral health perspective, it's important as we develop our levels of integration in the settings that we work in, that we adapt to the medical terminology that maybe some of us aren't too familiar with. And so that's why these slides are here for you. Terminology you're coming up with certain patients that you're working with, or in talking with your docs, your prescribers, or you're in any members of your integrated care team. This slide deck's here for you to go back and take a look at this. So nociceptive pain is pain that's caused by damage to body tissue. It's based on input by specialized nerves. And these nociceptors sense danger to soft tissue such as muscle, bones, ligaments, and tendons. And so this is a lot of times when our patients are talking about musculoskeletal pain. It's often described as aching or deep. And then neuropathic pain occurs when there's nerve damage, and it typically involves peripheral or central nerves. And this pain is described as burning, shooting, tingling, or electric. And then we have headache pain, and headache pain doesn't fall into really either of the two classes. It gets its own kind of category, and it's pain that involves disturbance of sensitive structures around the brain. It's usually in the forehead, eyes, upper back, and neck areas, and often described as a tight band around the head, pounding, throbbing, or dull. And so we're going to go a little bit more into some pain conditions. Again, we're not going to read all these in detail, but it's important that we begin to get familiar with this terminology if you're not already. Lower back pain is the most common form of pain and most fiscally costly worldwide in terms of medical visits and also loss of work productivity. And many individuals who experience lower back pain have really high levels of fear of movement, and they're prone to deconditioning of the muscles, which really exacerbates the condition. And we're going to talk a little bit about some interventions that we can help our patients with who may be experiencing fear of movement. Also, middle and upper back pain, a little less common, these bones are just don't move around as much, and so we see a little bit less of this. But herniated discs are also often a common area in the problem in the middle and upper back area, and then neck pain. Really a common issue. About 65% of the population experience it at some point in their life. Can happen, many of us have had a poor night sleeping where we didn't sleep correctly and we feel that muscle tightness, or possibly whiplash from a fender bender of some sort or an accident. And then pain conditions include also arthritis, and we're not going to go through all these, but a few of these to take a look at, to be familiar with. Wear and tear disease, that a lot of the arthritis conditions, it's really commonly associated with occupations that involve physical labor, so hence the wear and tear disease. But also tendinitis and bursitis. You hear a lot of times athletes talk about having problems with tendinitis from typically in sports involving repetitive motions like throwing a ball. And so those are there for you again as resources. These are some additional arthritic pain conditions. I think one of the two more popular ones that we see are peripheral neuropathic pain. This is associated with a lot of people who have diabetes. It's associated with high blood sugar, secondary to diabetes. And really a lot of times the pain is described as numb and tingling, pins and needles, electric, or burning. And that is often a very challenging experience for people. And fibromyalgia. And fibromyalgia is a disorder of unknown etiology and associated with a lot of pain, sleep problems, fatigue, and psychological distress. The pain is usually around trigger points, very tender spots in the back, the neck, sometimes the hips, shins, knees, and also described as a deep aching or burning. We know that folks with fibromyalgia are 3 times more likely to have comorbid diagnoses of major depression than individuals without. And so certainly something, if you're working from the pain perspective of patients with fibromyalgia, that we need to be screening for other comorbidities, especially depression. And this is a more specific dive-in of the third type of pain, headaches, these pain conditions, tension type, migraine, cluster headaches, also post-traumatic headaches, kind of similar to following an injury to the head. And then also an important consideration that we need to involve in the assessment when we're working with patients with headaches is medication overuse. And so you can use this as a resource if it comes up for you. Again, these slides are resources also, but it's important that as, especially those of us in behavioral health, that we're adapting to the pace and the understanding of primary care. And so we get used to talking about some of these medications that we typically aren't familiar working with. And important to understand what your patient is taking and how it may impact them. One of the things I do want to point out that's very interesting, that I had the opportunity to work with a doc in our health center who was fortunately trained both as an addictionologist, but also board certified in chronic pain. And one of the things that he was able to teach me about and many of our patients is the use of antidepressant medications. And that many of the antidepressant medications listed here on the right, it's the box second from the bottom there. But medications like Elavil and Cymbalta and Effexor can have tremendous side effects in a good way to help our patients manage chronic pain. And we're going to see why that makes sense in a little bit when we talk about some of our behavioral health interventions in the biopsychosocial model and the cycle of addiction, about how impacting emotions and impacting how we think and also impacting our ability and our physical body of being able to relax is certainly going to contribute to our ability to self-manage pain. So this is a list of some of the invasive medical treatment options for chronic pain. Some of these, again, just to be familiar with: trigger point injections, spinal cord stimulation, and surgery. All these are listed here for your review. I don't want to go through all these. Really not the scope of our webinar, but important that you have this as a resource available to you to make yourself familiar with what's going on for the patients that you're working with. And then the medical options for chronic pain. So physical therapy is the reduction in body movement that can be related to, can address the reduction in body movement that's related to fear of pain or re-injury. It's really can be a fantastic way of helping our patients and our clients increase their range of activities, from stretching to strengthening, and using things like therapeutic pools or stationary bikes, and also have coaching along the way to really help patients overcome the fear that they have surrounding pain and the fear they have of re-injuring or injuring themselves worse. And then cold and heat. It's an application of cold and heat. It's often used in the management of chronic pain. It's effective for many people. It decreases sensitivity to pain, but what it really does is it develops and provides a competing sensory central nervous system input, and that helps the body reduce pain sensations. And so it's kind of this yin and yang of using cold and heat to create this experience. And then electrical nerve stimulation TENS. This is a form of using a mild electrical current. It's not strong enough to hurt the muscle, but instead actually interferes with sometimes disruptive transmission routes around pain signals from the brain. And the electrodes are placed on the skin, and this can certainly impact and decrease the amount of pain. And then complementary or alternative therapies, sometimes called CAMs. Chiropractors can be extremely helpful in doing things like spinal adjustments or adjustment to other joint areas, and can provide a lot of relief to patients with chronic pain. Also acupuncture. Acupuncture involves using needles. There's specific needles, not needles like we typically think about, that are placed in certain trigger points in the skin and help relieve pain. Acupuncturists believe that it's a reorganization of the chi or the energy that is in the body that helps relieve pain in our patients. And then yoga and Tai Chi are a great way to help our patients re-engage in activity. It's usually a great self-paced exercise and engagement. And biofeedback, which involves really helping patients gain an awareness of how they think and what it is that impact has on their body and their muscle tone. And so the biofeedback machine measures brain waves, heart rate, and temperature, and gives a real-time report of the person's ability on how they can relax certain parts of their body and their overall relaxation state. And then relaxation training can be done, again, in biofeedback, but also different visualizations and even using hypnotherapy to help our patients relax. And so we're going to dive in a little bit and talk about some behavioral health interventions and really stick to our tried and true biopsychosocial model. So we're going to talk about the psychological factors, biological factors, and social factors, and some selected approaches that we can use. We're going to focus today, these are the strongest evidence base for non-pharmacological approaches to chronic pain, but today we're going to focus on ACT, CBT, and mindfulness. And so acceptance and commitment therapy is an approach, and it's based in mindfulness, and it really teaches the patient to observe and accept thoughts and feelings. And the key to that acceptance is that it does it without judgment and without trying to change them. And so it's as applied to chronic pain, that the idea is that it's the patient's struggle with pain that is causing emotional suffering and emotional distress, physical suffering and emotional distress. And so ACT really helps develop a greater psychological flexibility within the person, and they become more comfortable with the presence of negative thoughts, negative feelings, and behaviors associated with pain. And so what ACT really does is it takes the fight out of pain. Many of the patients that we work with feel like they're in the battle with their own body, that they actually get angry at their body. They feel their body let them down. They're mad at it. They're angry about the pain that they have. And ACT is a way of reframing that experience to finding compassion and care without judgment about those thoughts and those feelings, and finding an acceptance, the fact that they have this chronic pain. And the idea is with that acceptance, they can then shake themselves free to a place where there is somewhere to move on to, rather than being trapped in an unchangeable situation. And so cognitive behavioral therapy helps individuals resolve their problems around maladaptive emotions, behaviors, and thoughts, and uses a goal-oriented kind of approach. And so this, cognitive behavioral therapy is real popular. We hear about it quite a bit, especially in the treatment of depression and anxiety. It's also been very effective in use with substance use disorders, and now too for chronic pain. And we're going to dive a little bit deeper into that in a little bit. And then mindfulness, I also include in mindfulness hypnotherapy and guided imagery. But really mindfulness is an approach that combines the elements of relaxation, guided imagery, of helping our patients focus on the here and now. And what that does by focusing on the here and now and allowing a person to experience the present is that they learn to detach themselves from negative associations. And so really connected to pain management, the goal is to separate the pain sensation and unhelpful thoughts. Those thoughts that formerly would exacerbate the pain can be replaced and changed and let go of. And so we're separating the person from their thoughts, and can be extremely helpful in helping our patients relax and undo some of those cognitive distortions. So the cognitive behavioral model, and we take a look at the diagram, it's bidirectional in manner. And what we mean by that is that, specifically behavior impacts how a person thinks and also how they feel. And their thoughts can impact how the person responds to a certain situation or actually behaves in that situation. So an example of this diagram that we can think about is if I'm experiencing leg pain when I stand up from my desk or from my table, say, that I feel discouraged and frustrated. And then I start to think to myself, gosh, if I just do anything today, all I'm trying to do is stand up from this table. If I do anything today, it's only going to hurt me more. And that thought can lead me to say, forget it. I'm just not going to do anything today. I'm going to grab the remote and go plant myself in the couch. And that is an example of how this model, from behavior to situation to emotion to thought, can impact how our patients manage their chronic pain. The great news is that we can, through CBT, have a direct impact on that process. So by CBT, we can reduce the negative impact of pain on a person's daily life experience and use it to improve physical and emotional functioning, and increasing their coping skills for managing their pain, and really ultimately reducing pain intensity. So for the chronic pain model, we're seeing the situation that our behaviors A lot of patients that we're working with are avoiding or withdrawing, they're pulling back, and the impact on the emotions can be depression, can be anger, it can be anxiety. Anxiety is fear of hurting worse or feeling worse, anger that you're in the situation that you're in, and depression, hopeless, feeling like things just can't get better. And this can be exacerbated by our thoughts to the right. And so we're going to dive into this a little bit more, but catastrophizing and negative beliefs. And so this is the cycle that we see many of the patients that we're working with struggle with in chronic pain. And so we see the start of chronic pain leads to decreased activity and deconditioning, which actually exacerbates pain, and that leads to negative emotions, again, leading to our patients avoiding, withdrawing from their lives, and experiencing distress and more disability, and then the cycle goes on and around and around. And so some of the psychological factors from our biopsychosocial model, we're going to start out with psychological factors, are listed here. And one of them that I think probably is one of the most prevalent is catastrophizing. And so what we mean by catastrophizing is that it's the thought patterns that are assuming the worst. And they contribute to increased pain intensity, distress, and really limit the person's ability to utilize, adapt, or even consider some of the positive coping skills. So when you hear patients say things like, my pain is never going to stop, or there's nothing I can do to ever improve my pain, this mindset is going to interfere with any treatment interventions that we try and utilize if we don't address it. And so addressing catastrophic thinking is a key way to ensuring that any of the interventions that we use have a chance to be more successful. Another psychological factor is hurt versus harm, and this is when pain is interpreted as evidence of further tissue damage. We talked about this a little bit earlier. It's really the great fear, the fear that I'm going to harm myself worse, that I'm going to feel more pain, that the two of those dynamics are going to come together and I'm going to be in a worse situation than I was. And quite often this leads to decreased activity or inactivity. And then negative affect. The relationship between pain and negative affect, it's very complex. It's bidirectional, meaning that it's chicken or the egg. One goes before the other, one impacts the other, and sometimes we don't know which one came before the other. But we know that patients with chronic pain are more likely to experience depression and anxiety. And the increase in those negative emotions increase patients' reported intensity of pain. And so when we combine negative affect, it's kind of like turning up the volume on pain, where things start to just get worse and the person experiences higher levels of pain. And so CBT is a great example of how we can really impact negative affect to help our patients with chronic pain. And then answer seeking, and that goes in line a little bit with acceptance theory. Failing to accept the offered cause of pain or being unwilling. We talked about how chronic pain sometimes doesn't have an answer. We just don't know where it came from. And so this certainly can keep our patients stuck in a hopeless cycle of mystery that doesn't really offer them too many options on how to see things in a different way or get better. And then pain self-efficacy, and this is really a important, more adaptive belief about pain. It involves a person achieving a level of confidence that some degree of control can be exerted over their pain. So pain self-efficacy is the switch. It's kind of what we work towards. And we know that improvements in pain self-efficacy, they track with improvements in patient outcomes around pain. And so moving on to some of the behavioral factors, active and passive coping. These are two forms of passive coping, guarding, and also resting or underactivity. Guarding is keeping yourself safe, in a way by overemphasizing certain protective behaviors like limping or bracing or protecting certain parts of your body. And then resting or underactivity, it's over-resilience on resting. We talked about the impact that that has on how it deconditions the muscles and adds to atrophy of those muscles, exacerbating the pain. And then behavioral factors. So this is an active form of coping. So exercise, appropriate exercise and stretching has numerous benefits for individuals with chronic pain, but also is sometimes a difficult challenge to support our patients in getting engaged in it. And then the flip side of exercise is overactivity. And for some individuals, overactivity can be problematic, like pushing through pain and not following and ignoring their signs and signals around pain management can exacerbate pain. And so sometimes we have patients who are just pushing it too much. And so other coping skills that were really important for us to talk about is pacing, so engaging an appropriate level of physical activity without significantly exacerbating the pain. And this is the sweet spot. It's the art sometimes of what we do, of knowing when to push a patient a little bit, but also to restrict them and hold them back. Using things like SMART goals is a great way to come up with a good way to figure out behavioral activation planning around chronic pain. And then relaxation techniques. And these are techniques led to decreased perceptions of pain. One of the great exercises that we use is diaphragmatic breathing, learning to focus on your breath, breathing in and breathing out. Breathing in a mindful way helps to relax the body. It helps with emotional management, and it also helps to stop the mind. By focusing on the breath, we no longer can think about other things. And then social factors from this biopsychosocial model. So the solicitous significant other, it's someone in the family who maybe is highly responsive to the individual's pain or to their expressions of pain. And so we see this person sometimes that it leads to increased pain because they're overly engaging with the patient's behaviors around pain. And then the opposite side of that is punishing, that sometimes caregivers get angry or they just get fed up and tired. And caregiving can be a heavy and challenging burden. And so ignoring responses also has an impact that can exacerbate pain. So again, all these factors lead to and involve themselves in the chronic pain cycle. And so we know that utilizing things like cognitive behavioral therapy are ways that we can engage with those dynamics that we just talked about. We know that it's evidence-based. It's backed up by being proven across a wide variety of behavioral health conditions, and really helps our patients with their quality of life, and ultimately helps you develop a strong therapeutic relationship with your patients. And so the other components that need to be included in CBT are also talking about exercise. We talked about the value of exercise, of pacing, using SMART goals, and then developing a plan for a patient. Relaxation training, those are things that you can do in your office and practice with the patient. Also cognitive restructuring, sometimes means taking on belief systems like we talked about with catastrophic thinking, and behavioral activation. Getting our patients away from the couch in a way that is healthy for them, that doesn't overextend them, but also is on that sweet spot of pushing them just a little bit. And so this is a great way to look at a structure for treatment for 12 weeks when we're working with our folks with chronic pain, of how to take some of the things that we talked about and where to put them in your sessions. And so I'll leave this orientation for you to look at, but it's a great model of how you yourself as a clinician can kind of pace yourself. The other piece that we wanted to get into today when treating chronic pain is, how do we know if what we're doing is working or effective? And really the best way to know about that is by using measurement-based care. And that means using a measuring or screening tool. And the measuring or screening tool that we use, and this is an example of one of my favorites, this is the Subjective Units of Disturbance, it's SUDS. And the reason I like it, because I feel like it's real. It makes these numbers come alive. If you read number 2, it says a little bit upset, but not noticeable unless you took care to pay attention to your feelings and realize, yeah, there's something bothering me. That helps me understand what number 2 means, as opposed to number 3, where I'm mildly upset, I'm worried, bothered to the point that I notice it. And we won't go through the continuum of this. But this is a great way, and I think that a lot of the patients that I work with really like this, because it really helps give them language to a number when I'm asking them on a scale of 1 to 10. Where are they at with their pain? What's going on for them? These are some other scales that probably are very familiar to you, but if you're not using them, you need to be. Data is a critical component and a way that we can measure our effectiveness. It lets us know how we're doing on our treatment planning and if our patients are getting better. And also it's something for them to see in terms of when they come in and see you over a period of time, what's been working and what hasn't been working. So measurement-based care, if you're not using it, is a critical component. It's something that you need to add in, and be sure to be asking your patients every time you talk with them. And then this is just a great motivational interviewing perspective. MI is a great approach that I think works across the board, especially combined with cognitive behavioral therapy. And these are some effective tips on how to reframe and talk about pain. So you can take a look at the first one. You may begin to believe that it is better to try and restrict your movement. So that's the belief that our client may have. And our reframe is, you're going to learn about your body and make some changes that will show moving is actually helpful. So this really starts to change the way we frame and talk about pain with our patients. I won't go through each one of these, but they're really worth reading, because we all need reminders of how to be coming from a motivational interviewing strengths-based approach when it comes to pain management. And then finally, I just really think it's important to bring up sleep hygiene. One of the, I think I spelled it wrong, but you'll forgive me. But one of the really, I think, things that impact a lot of patients with chronic pain is the fact that they just can't get good sleep. And a lot of times that leads to a lot of the different impacts along that cycle of pain that we looked at before of chronic pain. And so focusing on things like their environment, using screens, thinking about the content of their conversations before they go to bed, focusing on tones of voice and conversations before they go to sleep are very important. The volume of the home, and when they're getting ready for sleep, to make sure that they're doing everything they can to prepare for minimal noise, that their lighting is appropriate, that the temperature is not too hot but also needs to be cool. The dangers of clock watching, where someone says, I need to fall asleep by a certain time, and they sit there and they stare at the clock. A lot of the cognitive behavioral interventions that we talked about can be very effective in this area. And then remembering, if you can't sleep, it's okay to get out of bed. In fact, it's a good thing, rather than forcing yourself to try and sleep. Again, bringing in some of the style of acceptance, the acceptance model, where it's okay if you can't sleep, and attending to that rather than trying to force it. And then managing stress and worries and using those relaxation techniques can be very helpful. So it's important that we also remember and go back to sleep hygiene for our patients. It can be a really important part of what's going on for them. So this is some excellent resources. On the next couple of slides, I want to make sure that everyone's aware of PCSSO. This is a program that is free. It provides doc-to-doc consultations for any of your prescribers out there, or any of you working with prescribers who want to consult with an expert. It's free. They also have a tremendous amount of research, information, and resources on their website to take a look at that. And these are our references. And I think, Libby, we might have just about 10 minutes to see if any folks have any questions.
Yeah, great. So continue to send in your questions to the organizer on the right side of your screen. We do have one question so far. Can you talk a little bit about the session time durations for these different therapies you discussed, or sort of how many sessions you recommend, things like that?
Yeah, it's a great question. And so the great part about the interventions that I talked about today work across a broad continuum in how we provide care. And so the sample that I showed up on the screen was 12 sessions. That was under the assumption that you'd be meeting with patients between 30 and 40 minutes. But also the work that I did in the health center that I worked in, we also saw patients for 15 to 20 minutes for brief interventions. And so a lot of this work can be done in a brief intervention model. And so it really depends on your situation and your treatment model. But many of the skills that we talked about today, all the skills that we talked about today, can be done in either a brief model or in a longer term model where you're seeing a patient for, say, 45 minutes or so. Does that, I don't know if the person can type back in, but if that answers their question.
Yeah, if you have any follow-up questions to that, please feel free to send them in. And we'll give everyone another minute or so to type in any questions.
Okay. So, I don't know if anyone does have specific questions, or even if anyone out there has a specific clinical question or case they'd like to talk a little bit about. Of course, we would ask that you protect confidentiality and speak in generalities, but we could go over some dynamics that you're attending to out there in your community. We'd love to get that part of the conversation going because I think that'd be most relevant for all of you. But one of the things that I just wanted to reemphasize is the use of screening tools. And, to be open about screening tools, I was never a big fan of using them. I remember when we, in our health center, first had to start using a depression screening tool. We used the PHQ-9, and it wasn't something that I really thought was necessary, because part of the PHQ-9, all of the PHQ-9 is all the DSM criteria for depression. I've been diagnosing depression for, over 10 years. I know depression when I see it. And so I was really annoyed that I had to do this screening tool with, all my patients that I'd been seeing, many of them, for years. And it was a very eye-opening, humbling experience when we started this, because I was so wrong. I missed several patients who were dealing with depression that was revealed to me by starting to do the screening tools. And I learned how that my clinical judgment is great, but it's even better and stronger when I use an evidence-based screening tool to help guide me. And the screening tools, the patients loved it. They really liked getting that number, talking about it, using it as a jumping off point to talk about what's going on for them and how they're feeling. They also love seeing the data. They love being able to see how they've been doing the last couple of months. It also challenged them sometimes on their own perceptions or thoughts of how they were doing. Some of them, especially around depression, many of them thought that they were doing far worse than they actually were. And the screening tools were challenging their negative thoughts, their negative belief systems about themselves. So I just wanted to make another plug for really encouraging you to incorporate and bring that some version of that Likert scale screening tool in to your practice when working with patients with chronic pain, because it really can be a game changer.
Well, it doesn't look like we have any other questions now. Anything else, Nick, you want to add before
No,
we wrap up?
no. Just everyone has my contact information, so if any questions come up or any feedback from the webinar, I'd love to hear from you all. And just thank you all for the work that you are doing out there in your community. We appreciate it.
Great, and thank you so much, Nick, for sharing your expertise and being willing to share with us today. As always, we share our gratitude to the Montana Healthcare Foundation for their support of this webinar. Once you leave the webinar today, you will receive a short survey on the presentation, and we would appreciate if you would complete that to provide your feedback. Thank you again for joining us today, and enjoy the rest of your day.